Hello, what's up, DSN? Thank you so much for joining us today. As you know, joining us are two of my favorite surgical studs. The topic of today's discussion is Be the Specialist, single implants. We're going to talk about placing onesies and twosies. And joining us today are the co-founders of the Colorado Surgical Institute, Dr. Daniel Brisky and Dr. Taher Doon. Also with us is Chris Richards, who's in charge of all things CSI. He's the brilliance behind the camera, we'll say. So welcome all of you guys. How are you doing today?
Doing really good, man.
Fantastic.
Thank you guys so much for taking the time to spend with your DSN brethren today. All right, guys, we want to jump into it. We have a lot of people that are participating, watching live here. So we want to make sure that we bring them as much awesome, tangible, tactical content as possible. So we'll start off by just kind of going over the whole concept of single implantology. As you guys may or may not know, Colorado Surgical Institute teaches a lot of different things. We talk about impacted wisdom teeth. We're getting into IV sedation. What we really hang our hat on is full mouth restoration through implantology, and full mouth restorations, usually using implants. But before you even get into full mouth restorations and implants, all on X type procedures, it's great to be super comfortable with being able to place single implants, how to treatment plan those cases, the basics of placing implants, doing treatment plans for those types of things, planning those out. So that's what we're going to talk about today. It's really, really difficult to go straight into all on X procedures if you aren't super comfortable placing single implants. So Dr. Doon, I'm going to start with you, and maybe you can just give us an overview of what you want to talk about today.
Yeah, in general, I mean, I was doing a coaching call recently with a doc, and he was asking about my evolution into creating a profitable business. And he wanted to implement, like you said, all on X, overdentures, all of that right off the bat. And that's not the way that it's done. It's implementing wisdom teeth, maybe a form of sedation, probably like oral sedation, and then followed with IV sedation and single implants, getting really proficient at socket preservation, doing quadrants of implants, restoring the implants. Doing that first in a chronologic way is going to build a good amount of profit for your business to then stack the all on X's on top of. So I think this is a really good place to start. It's getting really proficient at understanding how to do single implants and managing some of the complications that come along with them. And also the psychology behind when you're with a patient and something's not perfect, being able to just have that kind of candid conversation like you would about a filling that needed the occlusion adjusted or a filling that needed to get replaced. You got to talk about implants in the same way, like it's something you do all the time.
Yep. Dr. Brisky, let us know really quick. I know, you've been to hundreds of hours of continuing education, and now you are teaching advanced surgical procedures, but how can, the ability to understand the basics of placing single implants and being able to plan those out, how can that impact a general dental practice?
Oh my gosh, I couldn't talk enough on this one. Like anytime I talk about something, it's always about how to stop referring, because I'm so passionate about how do you keep all the stuff in your own practice and stop giving all the free throws and layups away to the specialist down the street, right? Obviously, the specialist is there for a reason, and we should definitely use them. We have some amazing specialists in our area too. But my speech is always, how do you stop referring stuff? And for me, that always started with, coming out of a residency, I started already taking implant classes during it. They told me don't work on the weekends and don't take CE, but I did both because I just didn't listen. But, I also thought that I could, even do an overdenture case or an all on X, but that's not true. Yeah. So you have to learn it in the correct steps in terms of what to put into your practice and what timeline to become successful and to keep yourself out of trouble. And my purpose is to shorten that learning curve severely for everyone in my life. That's what I get passion for. My passion is actually how to get people to the end game way faster than I did. So how do you, what do you actually start doing first in terms of wisdom teeth and implants, and when to start integrating, and how to decrease your complications? That's my passion.
Yep. Okay. Just so you guys know, we're gonna cover as much as we can in a 50-minute period of time. But our webinar objectives are implant surgical principles, how to avoid surgical errors, how to choose the ideal implant system, zero bone loss concepts, case planning, and how to be a badass implant dentist. So obviously, we're gonna just get in as far into the objectives as we can, but there are going to be subsequent parts to this actual theme. So don't worry if we don't get through all of the objectives today. There's going to be a part 2 and possibly a part 3 on this specific topic. So let's get tactical, Dr. Dune. Where do you want to go next?
Let's just hop right into it. I mean, obviously, like the slide says, it's a high stakes game, but really at the end of the day, this is, it's not easy, but it's easier than you think it's going to be. To dovetail into what Dr. Brisky introed with, this is the natural evolution of it. If you try to do all on X's and all those things, it costs a lot of money to market and stock your office appropriately from an inventory perspective. Single implants, these patients are already in your practice. You don't have to market for them. They're already there. So the revenue already exists, and all you have to do is add the procedure to the mix. So it's almost like instantaneous profit coming in to your practice. I want to kind of move forward to like the next slide, and let's just get into some actual didactics in terms of how we're going to assign the complexity of a case. We have we're in Colorado, we have all the ski slopes out here. We got the green, the blue, and the blacks, and the double blacks. And we just want to make sure that you guys start off in an appropriate way. Dr. Brisky, really boils it down well in terms of what type of cases you want to select from minute number 1. So Brisky, do you kind of want to walk them through how you kind of classified the complexity of these implant cases?
Yeah, of course. So green, blue cases, the first ones, there needs to be enough bone, right? And I'll go through some of the bone requirements. But where I got into trouble in the beginning was I would try to sneak an implant in a 6 millimeter ridge or a 5.5 millimeter ridge. And then you get, right? Then you actually get way less buccal bone, you get soft tissue loss, you start with 1 to 2 millimeters of bone loss, and you're like, oh my God, what happened, right? And all these things start going through your head. Was it that I drilled too fast? Was it saline? Was it infection? Was it the patient? Was it me? Was it the suturing? Like, you have to start integrating implants into your practice successfully, so you know the steps, and you're doing the steps in order so you can identify the actual complications as they come up. So in the beginning, you can't sneak implants into thin ridges. You need to do them on ridges that are wide enough. But sometimes in the beginning, when you're doing cases, it feels like we only get the crazy patients, or we get the patients that have no bone. So don't be fooled by this. One of the rules of doing implants in general is no crazy patients, and you do need to identify that there is actually enough horizontal and vertical bone circumferentially to place that implant.
What I would encourage everyone to do, what I found is a lot of people don't know how to read CBCTs thoroughly. If that's the scenario, there's not really any courses out there that go through how to read CTs. I would just message me or Dr. Brisky on the DSN workplace, and we can always set up like a Zoom call or do something to kind of just scroll through and show you how to evaluate your CT. Because if you can't read the CT, you can't plan the case, you can't evaluate if you have enough buccal bone. But a good rule of thumb is to make sure you're going to have 3 to 4 millimeters of buccal bone when you place your first, let's say 50 to 100 implants. Just that way, you're going to keep the complications in your practice down. We teach in the courses that 2 millimeters is the bare minimum. But a good rule of thumb is have double that in the beginning. You give yourself a little bit more wiggle room to place these implants on your first patients.
Mm-hmm. Even in an ideal world, the amount of bone you want is 4 millimeters on the buccal and 3 millimeters of soft tissue. That's like fairy tale land, right? So minimum is 2. That's the minimum that you absolutely have to have.
Yeah, and keep in mind when Dr. Brisky says soft tissue, we're talking about vertical height of soft tissue as well as horizontal thickness of soft tissue. There's actually 2 dimensions you want to be evaluating. And it took me like 7 years of placing implants to start evaluating the vertical thickness of the soft tissue as one of the indicating factors of where I'm going to be placing the implant as well.
So we recommend getting your at least first 50 implants done before you start moving on to some of these black diamond implant cases, which are more classified as, using more guides, vertical sinus in the way, immediate molars, compromised sites, full arch overdentures, right? Overdentures cases 1s and 2s, because there's a level of thinking that you have to even adopt to do an overdenture case successfully in terms of managing the soft tissue around the implant, how much bone reduction to do, right? In the beginning, you can only think or do so many miracles at a time. So I always recommend doing like 50 implants first, then you can start working on more complex stuff that you can also think about at the same time, because it's really hard to think about not only placing the implant, but the soft tissue management and then the bone reduction. Then you start stacking all these things on top of each other, and then you're more likely to forget one of the steps along the way.
So Dan, I'm gonna pause there. This is interesting and potentially counterintuitive for people. So you're saying you would like to see extensive experience and maybe 50 implants before you get into something like guided surgery. A lot of the people that go to guided surgery courses would say, well, I only want to use guides and not go freehand. And that gives me a sense of kind of security when I'm doing these surgeries. What do you guys both think about going straight into guided implant surgery before learning how to do things freehand and doing the planning on your own?
That guides. So the way I learned specifically was I placed 25 implants by freehand, and I struggled through it, and I forced myself to place all those implants first. The guide is a lot of the time can be used as a crutch, right? Like, and it would be like, what if we don't feel comfortable making the flap? Or what if we don't truly understand the 3D bone dimensional knowledge to place the implant? So sometimes we're using the guide as a crutch, and it's preventing some of our learning along the way in terms of how the bone is built, the 3D portion of it, making a bigger flap. That's why I always try to recommend people to, learn to take teeth out efficiently, do wisdom teeth efficiently, so you know how to flap everything. And then once you start placing more implants, then getting into guides to help you further understand implants.
Yeah, Mark,
Awesome.
that's a really, really, really good question. And I absolutely agree with Dr. Brisky. And I almost equate it to you're not delaying your growth, you're actually forever inhibiting your ability to get the tactile sensation in your hands. What I've noticed is when we have younger docs come through the course, they start to put things together a little faster. And the trajectory of their careers change more quickly. And it's because there's like this neural connection between the hands, and your brain tells your hands to do something and your hands will do it. And you have this sensation of what you need to be doing. And if you go to guides right off the bat, you're automatically taking the tactile sensation of learning out of it. It's like when you were surfing with the knee down, and it's harder to learn how to surf and get your feet up in the right way right off the bat because you've learned how to do it with a crutch. It's the exact same thing. You've forever made this harder to actually do it properly. So I agree with Dr. Brisky. You have to do it freehand in the beginning and then move to guides. I'm never going to knock guides, but what I will say is people who go to guides first and don't learn freehand, they're stunting their growth forever.
Yeah, and use them on cases that are more high risk, right? Use it on an anterior case, which is what I would do in the beginning, because you definitely don't want to mess up an anterior case, right? But for your more layup cases, that's why we recommend placing implants that way. Because someday, and this is what my dad taught me when I was first coming out of school, he's a dentist, and he said, son, like, do it the long way or the hard way first, because eventually that way will become the easy way. All right. And my implant visits that were 45 minutes. Now my implant visits are like 5 minutes. So that's the kind of speed that I want for everyone. And also too, guides can be expensive. It's another plan, another step that you have to keep track of in terms of labs and having someone else do that, or another lab bill you have to pay. So for me, on 1s and 2s, all right, easier cases, I love doing freehand.
Awesome. Thanks, guys. Appreciate that.
And so I guess to pivot back to case selection, if you're in the beginning, immediate or not, no immediates, but go to your first molars in your mandible or go to your premolars in your maxilla. Those are going to be the layups traditionally, if you have places to place your implants. Now, if your first molar has a lot of room and the sinus isn't dropped into the space, then you can incorporate maxillary first molars into that category. But the bone and the density of the bone tends to be more like that D3 balsa wood, you know, or D4 type of like styrofoam consistency in those regions oftentimes.
Yep. And be careful in some of the immediate implant cases you pick. In the beginning, I felt like, oh, yeah, I could place that implant, right? But then I get myself into trouble because I just wasn't sure, you know, if I did have an implant failure, which part of it failed. Was it the hole I drilled? Was it the bone grafting? Was it the suturing? All right. So identifying what are the problem steps and the complications of why you actually had that happen. So that's why, again, we wanted to kind of go in that sequence so you can start identifying that you can place the implant correctly and you're not overheating bone and you're having the correct suturing. And then you just start stacking all these steps on top of it. And eventually you'll be doing some full arch. So just general principles, right? We need minimum 1.5 millimeters of bone circumferentially. We prefer 2. Minimum space between tooth to tooth is 7. So, you know, if you have a 4 millimeter wide implant, right, you're going to need 3 millimeters of bone or 1.5 on each side. So 4 plus 3 is 7. So really in the beginning, the minimum implant or minimum ridge width that you should be really attempting is about 6.5 millimeters. And that's for a 3.5 millimeter implant, which is the smallest that you could do in that. And that's if you're precise, right? Like what if you start your osteotomy, and we'll talk about this in a little bit, you need to start your osteotomy more lingualized, but what if you accidentally start it in the middle of the ridge? Then by the time you're actually placing the implant, you're gonna already have tooth in a bone. So that's why, you know, give yourself some running room in the beginning to learn from your own mistakes. Pick some of those 8 millimeter wide ridges in the beginning. So you can start learning how to place an implant starting off with your drill crestally, right? Way more lingually instead of in the middle of the ridge. And buccal lingual distance, yep, greater than 6. Otherwise, you're getting into all those advanced techniques. Way too hard to squeeze an implant in. And see the bottom one, non-crazy patient. So don't pick the crazy patients in the beginning. Yeah, you'll get yourself into trouble. Avoiding surgical errors. Plan every implant on a CT. I do believe nowadays you really need to have a CT. It's so nice to just, when you're drilling the implant hole, you can place it on the implant already. You can already place the implant on the CT and you can reference that, turn around and say, hey, where am I? And you kind of look in the mouth and you say, hey, this is where I am in the mouth. And you look in the CT and you say, this is where I am in the CT. So
and then when you get proficient at planning your CTs, I actually will plan out the implant placement on my CT in front of the patient. And it actually qualifies you in front of them, because most people will just show them the CT scan. But if you can actually run through it in front of them, I've noticed that my case acceptance went up when I added that to the mix.
So
that's a good idea. Yeah, so I have
question for a lot of people that are getting into the implant game for the very first time. If they don't have a CT, is the first question, and then learning how to interpret and plan on that CT is the second big question that people would have. So what do you guys think about those two big questions?
Yeah, if I'm getting behind the podium and saying things from a medical legal perspective, I'm going to say get a CT scan. And I'm also going to say from a realistic perspective, what I did in private practice when I learned on a pano and a PA. And then I literally have a caliper and measure the ridge pre-surgical to make sure there's enough width. And then you have a kind of a gauge on what tissue thickness is, and you do the math and you just pick the ones that are really layups. Because if you don't want to spend the money to get a CBCT, but you want to do a few implants and just see if this is for you, I think that's okay. You have to go into it understanding that if the case goes legal, and typically speaking, cases don't go legal, but if it does and you don't have a CT, you're skewered on that one. Like it's game over, you're settling. all of that. So it just depends on your risk tolerance level. And then when it comes to actually getting a CT and getting introduced to the game, I like Voxel as an educational partner. They will just educate you without even trying to sell you a CT, and they can talk to you about the benefits, and they have some really low cost introductory CTs to get into it. So they're a good resource to talk about that type of technology as well.
And there's even software out now. Blue Sky Bio actually has an AI setting that plans the implant for you in some of their software. So it's pretty cool. So like literally there's even fallbacks. You're like, oh my God, I don't even know where to start with this. You know, you could definitely shoot me or Dune a message. I have a lot of people that will just send me a Blue Sky plan, and then I'll change a couple of their implants and I'll just send it right back to them. And then I send them a couple of different texts. Hey, this is where I'm going to place the implant, and this is why. Right. So all of that stuff. And the reason why I love Dental Success Network is because of how amazing this community is. And anyone that has an issue or an idea, how do you plan this implant? Post it on DSN, and you're going to get a very fast response from someone that would be very happy to help you out.
For sure.
So in the beginning with implants, I feel like, and even still, the most confusing part is what implant do I use and why, right? Like what is going on? Why are all these people saying use this system or use this system? Like why? Like what's actually going on here prosthetically and surgically, and how do I pick an implant that is going to be the best for my own practice? And Dune and I, when we first started on our partnership, and we would even have disagreements like, hey, I want to place this implant, and we want to place this implant. And we didn't really, even a long time, 5-6 years ago, we wouldn't even know why we were saying that, right? You just thought that this is the implant that you used in the past, and you liked the brand, or you thought it was good, but there wasn't really any research behind it. So now that all these textbooks are out there, like a Zero Bone Loss Concepts book, the research is there. Like there's a specific reason why you're going to pick that type of implant for your practice. And those ideas are all based on, right, something that's platform switch, something that is internally indexed, something that has a conical connection. And conical connection is identified as something less than 20 degrees. The implant needs to be versatile. You can use it in the full arches. You can use it in single uses. You want wide range of diameters. So you want something that's narrow. You want something that's larger. You want something that can be aggressive or even non-aggressive. You want something that's high initial torque. You want something that's Nobel compatible, meaning that the top or internal geometry of the implant, that you can actually use different parts on it. So, right, just like kind of like Legos, take one up, put the other one on, and something that's not going to go away. And also too, cost. Personally, I don't want to pay for the cost of a very expensive Astra implant. So I would rather pick something that's a little bit more affordable.
Yeah, I completely agree with everything that Dr. Brisky said. And at the same time, keep in mind, a lot of us have tested out all these systems for you guys over the years. And then we've settled on Neodent as of this conversation, as the one I would use in private practice and the one that we teach at the courses.
Yep, we had a couple companies chomping at the bit to try to get into our surgical institute, but Dune and I held very strong to our opinions here, and we had a lot of discussions about, because him and I have used pretty much every implant system out there, so we had a couple different hats in the ring, but we decided on Neodent because it's following the actual research of implants. So ideal implant system, everyone needs to read this book. 100% Zero Bone Loss Concepts. Please get it. Please read it. It talks about how to achieve crestal bone stability is how it means. Because even back, in the 90s or 2000s, we would qualify an implant as being successful if it had 1 millimeter of bone loss over the first year and a half or two. Like that, nowadays we say there should be 0 bone loss within that first year or two, because there's ways to actually do that. And this is the part where this type of information is so valuable. And we'll talk a little bit about surgical and some of the prosthetic steps along the way to actually get there. So
when I communicate with, sorry to cut you off, Dr. Brisky. When I communicate with my labs, I actually will ask them if they know the Zero Bone Loss Concepts book. And I ask them to purchase it and reference it when they do my cases, because that's how I want my prosthetics done these days.
Yep, 100%. So zero bone loss, just like I was saying just a second ago, 1986 article, they qualified an implant success as 1.5 millimeters of bone loss in the first year. And then they even said an annual bone loss of 0.2 was considered a success. That's not anymore, right? So surgical concepts, we'll talk about implant design, placement depth, the vertical soft tissue thickness, so how much soft tissue you can actually achieve and how to do that, and about the attached gingiva around the dental implants. So implant design, right? We don't want to place a polished collar below the bone. Reason is you'll get bone loss. So polished collars need to be soft tissue level or supracrestal. Polished collars will not osseointegrate, which means you'll get bone loss down to where you put right down to the threads as where of the implant you just placed. Microgap is the connection between the implant abutment, which results in bacterial leakage, obviously, because you have your connection at the bone level, and if it moves, you're going to get bacteria, and bacteria is going to lead to bone loss. So if you move the microgap away from the bone, you'll minimize the bone loss, right? So you need a better sealing of the microgap to allow for less bone loss. So platform switching is where the implant has a diameter that is smaller than the implant diameter. So that way the bone actually grows over the top of the implant and it protects the microgap because the bone is there. So it has decreased bone loss. So conical connection, a conical connection basically means that when you have the implant and the tooth goes on top, it creates such a firm cold weld because of the less than 20 degrees taper that the microgap no longer moves because it's cold welded, it's sealed, it's one piece now. So now there is no movement from the implant to the connection. You won't get bacterial leakage, right? And you will have stability in terms of never having bone loss around your implant.
Yeah, one thing that's really cool that happens is even if you remove the prosthetic screw, you still can't remove the abutment and crown. You'll need forceps because it's so welded in there that the connection in itself is firm enough where you have to actually physically grab pedo forceps and put some gauze around the patient's tissue so you don't pinch them, and you squeeze and you have to pop it up and out to release the cold weld.
Yep. So platform switch picture, right? Bone grows over the top. Implant design, there's a couple of different connections, right? External, there's internal, and there's conical. Internal connection that has been replicated like thousands of times, right? This is a Zimmer implant, a Nobel implant, a BioHorizons implant. They're all the same connection. They just are. So conical connection is a little bit different. That's with a few specific implants, like a Megagen or a Straumann or a Neodent. Those are some of your deep conical connections. Neodent has a 15-degree conical connection. Straumann has a 16-degree one. These are the types of implants we recommend using. So implant design, conical connection, right? This is where you have that 16-degree Morse taper connection, and you can actually place the implant below the bone. Not all implants are designed to be placed subcrestal. This is another internal hex. This is an internal hex implant. I do believe that these types of connections are becoming a little bit outdated, to say the least, like a Zimmer, BioHorizons, Nobel, that type of stuff, because you have to place the implant crestally or 1 millimeter below. So that micro gap, a lot of the time when you're looking on Facebook, you see someone post an implant picture, it's usually a complication because of not placing the implant deep enough. But if you place the implant too deep, then you get bone loss down to the top of the thread. So you just don't have as much wiggle room in terms of success rates later.
Can I pause for a second, guys, and go back to platform a little bit?
Yeah.
People that are new to the implant game might not understand what we mean by platform. There are some really popular implants that have different platforms that make things a little bit more confusing, I think, and particularly for the team when you're trying to line up the armamentarium for actually placing the implant versus temporizing the implant versus restoring the implant. That can get a little bit confusing. That's part one of my follow-up platform question. And then the second is, where should we be looking as far as a general price range that is fair? When we're saying that Astra is a little bit more expensive, and then there's some other ones that come in a little bit more reasonably, but are still a quality product. Where is that range?
Yeah, to address question number one, from like a Nobel Active perspective, the platform is the internal part of the implant. So imagine the implant is external threads, and then there's internal threads. So the internal component of the implant is what we're going to be referencing. Like Nobel will have a narrow platform and a regular platform and a wide platform. So if you have a 3.5, or let's say you have a 5mm implant, you could have a narrow, a regular, or a wide, which means your abutments, you have to stock 3 abutments for that type of implant. Where if you pick like a Neodent, well, their platform is the same across their 3.5, their 4, their 5, their 6. So you're only stocking one set of abutments, one set of impression copings, one set of healing abutments that all fit that same platform. And then it's almost like a mathematic equation of how expensive is your accounts payable going to be if you have to stock up enough if you're doing surgery in your practice. And it gets very cost prohibitive for people when these platforms when companies have multiple platforms, and they obviously do it by design that way to maximize profit from the dentist. And then part two on that question is going to be cost. I mean, I think a fair price point is going to be about $150 or less. If you're paying more than $150 for a single implant, for any reason, just reconsider why that's happening. It doesn't mean you have to switch your system, but just at least be aware that the price point might be high. And then also your implant companies should be throwing in a lot of the cover screws, healing abutments, different things for you to decrease the cost per case if they want your business. And I'm sure I missed a few things. And Dr. Brisky, I know you probably have a few things to say on that too.
Yeah, of course. Well, there's a difference between, let's say, a platform shift versus a platform, right? So platform shift is just, is just the fact that the abutment diameter is smaller than the implant. So it keeps the micro gap or the connection away, which means more bone stability because bacteria can't get to it. That's the only thing for a platform switch. But as far as platforms for implants, yeah, it can get extremely confusing. Like Dr. Dune said, you're gonna have an entire wall full of healing abutments and prosthetic sizes and all this stuff. It is very confusing. These modern day implants, when you have a conical connection, the implant is placed a little bit deeper. So when you're restoring the implant, it's going to be a little bit more of a gradual emergence, and it has more room to come out of the implant and out of the bone to get a better contour. A lot of the implants would have these different platform sizes because the implants were placed crestally one when they're below, so it almost looks like an apple on a stick. So if you have a wider platform, now the apple on the stick doesn't look so much like that, right? It actually is a little bit wider, but that's kind of like the whole point of that. But nowadays, when you have an implant that's placed deeper, it's eliminating the need for all these different platform sizes because you have the ability to have all of that emergence come out, so it looks more like a tooth.
Yep, I would add from the cost perspective, beware of gray market clones. If you are concerned with price, which I believe everybody should be, I think that particularly if you're ordering through DSN, and we have a number of different implant companies that you can get discounts with through the DSN buying network and Synergy, et cetera. There's enough legitimate companies, whether or not you like multi-platform or you like single platform, that you can get discounts from, so you don't have to go into the gray markets just to save $50 on an implant. We have negotiated enough good prices there. So stick with some of the major suppliers and some of the major companies that have, tried and true, and they're not kind of pumping out sketchy stuff. The last thing in the world you want is to place 25 implants on a gray market clone and to have them start failing in 1 to 3 years and to have to replace them all. It's bad situation. And I've seen that happen before.
Very true. These are the three main types of implants, right? You have tissue level, bone level, and with a plot, right? Tissue level, bone level are the biggest ones. If I had an implant placed on me, I would actually want like a Straumann tissue level implant for my first molar. Those things have like 99% success rate on them. And the reason is because the polished neck is completely out of the bone. There's no way that bacteria can attack this thing. There's no microgap. There's no microgap. There's no way bacteria can actually adhere to it. So amazing implant. Only negative again is it costs so much money to place one of these. So I think the best middle ground now is placing an implant, or get a bone level implant or subcrestal implant, which has that type of conical connection, which keeps the microgap away as well. So it's kind of some middle ground. So implant placement depth, as with a lot of these implants too, because it's a conical connection, and you can place it subcrestally, which is pretty cool. They even have this term floating around of abutment integration. That's another one. So, years later, this is the implant. It was an immediate molar, and this is what it looked like, 2 years after. And look how much bone is surrounding this healing abutment. Right? It's amazing. You have so much room for, 10, 15, 20 years down the road. This implant is still going to be stable. You're not going to have that half, 0.2 millimeters of bone loss every year, or risk having a lot of peri-implantitis, because no bacteria can attack that interface of the implant and the abutment, because it's cold welded and because it's below the bone. So vertical soft tissue thickness, minimally, we want 3 millimeters. So now there's all these ideas of a biological width, not around your crowns, right, but around your implants. So you want a biological width or vertical soft tissue thickness of 3 millimeters. And how do you get that, right? Let's say you take an implant, let's say you make this incision right here, and you're measuring 2 millimeters of soft tissue. Well, at that point, if you place the implant at the level of the bone, what's above the bone is still 2 millimeters of soft tissue. But if you place an implant 1 millimeter below the bone, now you're going to have 1 additional millimeter of soft tissue that grows. So now you're going to have 3 millimeters of soft tissue. So the whole idea is the way you create zero bone loss around your implants is that number for the vertical soft tissue thickness has to be minimally 3. I personally go for 4 is what I go for. So on a case where I have 2 millimeters soft tissue thickness, I'm going to place my implant 2 millimeters below the bone. And now you're going to have a total of 4 millimeters of soft tissue thickness that's above the top of the implant.
This part is so critical. This is your long-term success. This is your practice not having revisitations in 5 years and 7 years and 10 years on your cases, if you can follow this principle. And this took me 7 years of placing implants to finally put those pieces together of why it's so critical to not only think about your implant from a prosthetic design. Everyone's like, oh, we'll design it where the access hole comes out through the central fossa of the tooth. Well, more so than not, it's really the soft tissue is going to be, the most important thing surrounding this implant and where you place it subcrestally. And Dr. Brisky has kind of explained that perfectly.
Now we'll kind of visit like the last couple slides we did. Now, Dr. Dune, if we placed internal hex implant there, why would that be? What's the biggest difference between an internal hex implant at that site if you place it crestally versus placing a deep conical connection implant there?
Yeah, more so than not. I mean, you're only going to have your 2 to 3 millimeters wherever you're measuring of your soft tissue thickness. B, my emergence profile on that crown that I'm going to have in the future is going to look more like an apple on a stick versus this nice emergence profile with soft tissue kind of filling in the papillas and having a good bacterial seal for the future. And then 3, you have a very short abutment that you have to make. And the deeper you can place it, obviously, hopefully there's no like, vital structures underneath that inhibits your ability to go 2 millimeters subcrestal, but you need more prosthetic room so you can have more integrity of your abutment and crown and that whole interface.
Yeah, exactly. Because you don't have the ability to control your vertical soft tissue thickness, which means zero bone loss. So if you place an implant that's internal hex, it has a micro abutment or it has a micro gap. So if you place it two below, your micro gap is going to contribute to having bone loss, right? So that's why we love these types of implants with a deep conical connection, because you have the ability to control all these scenarios like this. You can measure the tissue. You can purposefully place an implant to the exact depth that it takes to have no bone loss for the rest of that patient's life, knock on wood, which is pretty cool.
Yeah. And the one thing that this slide doesn't depict is it shows where we made the incision and it shows we're measuring vertical thickness, but you want to look at the horizontal band of keratinized tissue. And if you don't have a good horizontal thickness of your keratinized tissue, beautiful, then you're going to make your incision more lingual. So then you can push and roll that buccal keratinized tissue towards the buccal of the implant. So now you're taking into consideration your vertical soft tissue thickness as well as your horizontal soft tissue thickness when you place this implant.
Yeah. Dooney, have you ever buried an implant and then you've gone back to uncover it? And then you said, then another couple months later, you had a millimeter or two bone loss. And you're like, what happened?
Yes. And it's usually because there's a little pinpoint opening in the tissue right above the cover screw where the tissue didn't seal perfectly.
Yep. That's one. Yep. That's one of the biggest ones is suturing, right? That's why we really like using healing abutments. And another reason too, let's say you're doing more of a miracle case where you have to do some GBR and you put an implant in and then you covered it up and it looks perfect. And then you go to uncover it. And guess what? If you don't have the vertical soft tissue thickness and the implant wasn't placed deep enough, the biology is going to happen to that implant as soon as you uncover it and put something on top of it. So you will inherently cause another millimeter or 2 millimeters of bone loss because we still wanted to have thought about the zero bone loss concepts, right? Of placing implant deep enough and how thick was that tissue. And maybe in the future, we would start adding some things like, how do I do a soft tissue graft at the time of an implant uncovery to add some more soft tissue thickness, right? Like little principles like this, which are fun. I thought this was so fun when I was going through this whole evolution of learning implants, because you'll start placing implants and you'll go to a soft tissue class and you start improving these little aspects. And for dentistry, I love dentistry so much because there's limitless amount of knowledge that you can gain on these topics.
Yeah, and I know we're running a little short on time, and we will absolutely do a secondary part to this to kind of wrap this up. But the soft tissue part cannot be, under discussed. So we might even come back and touch on it a little bit. One thing to consider though is the aging population is getting astronomically more weighted in the United States because people are just living longer and longer and longer. More GPs are placing implants. Like the addition of this into your practice is an absolute game changer. I mean, the implementation of surgical procedures into my private practice has changed the trajectory of my career. So for anyone listening to this, I would strongly urge you to take on some of these cases in your practice. It is very, very rewarding to do this.
Yeah, people don't want to go on a tour of their city to try to figure out what to do, right? They don't want to go to someone else. They love you and they want to stay with you and they want to be faithful to you. So patients that are leaving, they don't like it. They may never go for the consult to that specialist down the street, right?
Yeah, the double arch I actually closed yesterday, had already seen the oral surgeon GP combo, and they came and found us because we did everything in one place. So your ability to do everything in one place is absolutely a good selling point for you as a practice from a marketability perspective. So Mark, how are we doing on time on this? Can we keep pushing forward or?
Pick up a topic that you can open and close in 3 minutes.
Man, I would just say we have more so than not, like you should do hands-on courses when it comes to this. And I understand I'm going to be biased in this recommendation, but what we've created at Colorado Surgical Institute is hands down, I think, one of the best courses that is going to be stateside or international. And the reason why is Dr. Brisky and myself, we've pretty much between us done all of them. And we've taken all these concepts and included them into what we have at Colorado Surgical Institute, or CSI, as we like to abbreviate everything. And we get you a volunteer license to come out and do cases like this. We take the time to actually talk to every attendee and figure out like the difficulty level of the cases that you want. Some people request vertical sinuses. Some people request the slam dunk easy cases. Like, hey, I'm brand new. I'm doing my first implant ever, and I want the cases that I can go home and do. And we set those up. The same thing with wisdom teeth. So it's just a really customized course we have going on. We have 4 more ops open across the entire weekend for June. And we have a couple of arches open in August. And so from that perspective, I would say reach out. You might reach out to Chris Richards, who we introduced earlier today, to reserve that spot, because I have a suspicion that once this actually goes live to the DSN community, that it's going to be gone pretty quickly. And we want to get you the volunteer license and everything set up so you can come out. And we have patients waiting. The cool thing about the area in which Dr. Brisky and myself practice is it's rural, it's teachers, it's farmers, it's agriculture, it's the oil industry, and they are very down to earth, cool patients, and they're super appreciative of what we're doing for the community.
One of the cool things about Colorado Surgical also is that, again, you are stateside. And I've been to some of the international courses, and you're just, you're guaranteed 30 implants and you're placing them in all different directions. You never know what happens to the patient. There's no, promise of post-op care for those patients in the third world. And there's a very good chance. In fact, I know for sure that there's no attempt to restore any of the implants that you're going to be placing there. So there is a big emphasis on post-op care here at Colorado Surgical, because they are actual patients that we will be continuing to see in Dr. Brisky and Dr. Dune's practices. So, ethically that it's the best place to get the training, because the post-op care is going to be there and the restorative plan is already in place. So that's a huge part as far as something to consider. And if you're going to amortize all of the, the price for getting, your visa and your passport and traveling internationally, I'm telling you that the cost is extremely comparable, if not more cost effective to stay here domestically and go to Colorado Surgical. One of the cool things is that Dr. Brisky is going to be hosting this next course. So anybody that's doing onesies and twosies and doing their first dental implant, if that's the direction you want to go, the first 2 days of this 3-day course, the Thursday and Friday, are going to be at Dr. Brisky's office. So there are some spots available for that June 8th through 11th. Just go to Colorado Surgical, Colorado Surgical, Colorado Surgical, or you can reach out directly to Chris Richards, Dr. Brisky, Dr. Dune, or myself. You could DM us in DSN as well to get more details on that. Ashley, I'm going to bring you up.
Yeah.
To close us out and to let people know how they can get their continuing education credit for this last hour they spent with us.
Yep. If you are still with us in the Zoom chat, I posted a link in our, again, it's in the Zoom chat. You had to be live with us here. Just go ahead and fill out that survey and you should automatically get a CE certificate. And yep, as the docs mentioned, we'll go ahead and set up a part 2 for this, and there will be more.
There will be more. So thanks everybody for attending. Thank you, Dr. Dune, Dr. Brisky, and Chris Richards, and of course the GSD queen herself, Ashley Hirschfeld. Everybody out there for attending. Can't wait for part 2. Stay tuned. We will wrap up this presentation at the next live webinar. Thanks, guys.
Cool. Thank you, man.
Awesome. Thanks, Mark.
Bye, everybody.
Bye, guys.